Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Anwar Shahzad. Today we will discuss an important topic of gynecological cancer, that is the endometrial carcinoma. So it is the uterus has got three layers: the endometrium, myometrium, and serosa. So this endometrial cancer, though it comes after the cervical cancer, it is less common than the cervical cancer, and it is the cancer of the post-menopause age, and presents with this irregular vaginal bleeding, hypogastric pain, and pyometra, etc., etc. So we can see that this cancer has got two stages, that is two states. One is a pre-malignant stage, there is a malignant stage. The pre-malignant stage consists of the hypoplasia, that is the hypoplasia of the glands of the endometrium. So in the routine, there is a proliferation of this endometrial glands and endometrial stroma under the influence of the estrogen. But when there is more estrogen dose or persistent estrogen available, then the more glands and more stroma, the more proliferation is there. So this makes the simple hyperplasia into the complex hyperplasia. So the hyperplasia, which is a pre-cancerous stage, is the shows in the form of the endometrial thickness. Endometrial thickness is more, if it is more than 12 millimeter at the premenopausal stage and more than 5 in the postmenopausal stage, it is called as this hyperplasia. So it can be simple. Hyperplasia can be complex. So, and simple can be again without atypia, with atypia. And complex hyperplasia is again without atypia and with atypia. That is, the cancerous cells are there. Cancerous cells mean the nuclear size is more as compared to the cytoplasm size. Normally in normal cells, cytoplasm is more than the nucleus. And in cancerous cells, the nucleus becomes bigger and cytoplasm becomes smaller. So this is atypical cells. So if when of course we will see the atypical cells, then we call it the atypia, and if no atypical cells, then without atypia. So there is a percentage that this hyperplasia can be transferred, can transfer into the endometrial cancer. In case of simple atypia, a simple hyperplasia, there is only 1% chance. And in case of this simple hyperplasia with atypia, there are 8% chances. And in case of complex hyperplasia without atypia, there are 3% chances. And in case this is complex hyperplasia with atypia, there are 30% chances. So when there is atypia, there are more chances of being converted into the CA endometrium. So we can confirm the patient when presents with the vaginal bleeding, irregular vaginal bleeding, and this hematometra, this pyometra, and we do this TBS, and then we can we take the biopsy by Piper or by this fractional curettage, and if we stage this cancer, that is a C endometrium, the more common is the endometrial carcinoma, less common and more malignant are the clear cell carcinoma, and this one is another also. So these are papillary cell carcinoma. So when we do the fractional curettage, they will take the biopsy, so we can come to know that what is the type is. So if we stage the cancer, that is stage 1, 2, 3, 4. So one stage is less than 50% penetration of the myometrium, 1A. 1B is more than 50% of the penetration of the myometrium. And stage 2 is it involves the cervix. Stage 3 involves the serosa, adnexa, and parametrium. And stage 4 involves the unibladder bowel, 4A, and 4B is the pelvic and aortic lymph nodes. Similarly, and this is the staging. Now, the treatment. Treatment is in 1A1, we can do THBSO. And if no lymph nodes are, of course, involved, no lymph node clearance is done. It is also said the staging of the endometrial cancer is by surgical staging. That is, first we do the THBSO and the lymph nodes, and then we come to know that what is a stage. So we mostly we have already done the much of the treatment, and if this is stage 2 is 1B1 is there, then it means and the lymph nodes are involved, then we do the radiotherapy afterwards as well, and lymph node clearance as well. And in stage 2, we do the vertebral mastectomy, lymph node clearance, and radiotherapy afterwards, post-operative. And in stage 3 and 4, we do the debulking and lymph node clearance and radiotherapy and chemotherapy afterwards. So this is the treatment, and of course we should involve the other specialties as well. That is a multidisciplinary approach, and especially the oncologist, radiologist, and oncologist. So usually we, after diagnosing the case, we refer the patient to the oncology department, so that the patient may be properly treated and have got the maximum relief. And with this, thank you very much. Goodbye.